you have pain and dysfunction right now. If I can get you to a state where you're like, most of the time during the week, I don't think about this body part anymore, and I'm functioning pretty well, and it doesn't register for me, I see that as success. Yeah. And if we have to utilize this again because Shockwave did great for you, and we do 3 sessions here and 3 sessions there, and that kind of keeps you maintained and hones that area that is a problem, that's success to me.
Welcome back, everybody, to another episode of Bio's KOL Sessions. Today we have the privilege of having with us Dr. Brice Blatz. He is the founder and president of ASMST, the Shockwave Society that's bringing out really cool data. He's also the CEO and founder of Maple Medical, where he practices. Thank you for being here.
Thank you for having me.
Just on a personal note, you were pretty much the guy I turned to get my Shockwave devices a few years ago. So thank you for that, and thank you for kind of being one of the pioneers, if you will, in this field. Tell us a little bit about your history. How'd you get into Shockwave? I think it's been around a little longer than people think. Yeah. So how did it all work out for you?
Yeah, so the very first machine I had was this one right here. This is the Radial pressure wave machine. And for those of you that don't know, my father's an orthopedic surgeon. I worked with him for about 7 years in the Bay Area. And so when I got fresh out of fellowship, we were working in the OR together. And it was a Zimmer rep that would be, walking the halls of the surgery center, selling all of his wares. Yeah. And one of the things they were trying to make him sell was this machine. Yeah. So he went and talked to all of the surgeons, and the surgeon's like, I don't even know what you're talking about. Yeah. And so I would see him like once a week, and he said, you know what, you're into this cutting edge stuff. You're doing biologics. Like, can I introduce you to this? And he's like, I'll let you use it every time I see you here. Right. And so I had an ankle injury that I was dealing with. I'm like, sure. So I did it 6 weeks in a row, completely fixed my ankle. Wow. I've never had an issue since. And so at that point I was like, there's got to be something to this. So I started doing the research, and then worked with Curamedics there who hooked me up with this first system. And they didn't have a lot of people kind of in the sports medicine orthopedic space. They had a lot of podiatrists, they had physical therapists, but they're like, would you be interested in starting to, lecture and meet some other people doing this? So I think it was 2018 where we had a big summit, and that was the first time they brought some of the Europeans over who have been doing it for, 20 plus years.
Crazy, right?
And I got to just dive deep with these guys, and I was like, wow, it's way beyond what I even thought was possible. And so ever since then, I've been, lecturing on the national stage, international stage about this stuff, meeting all those guys every time I do it, just to try and raise the level of the education and the research. And honestly, we're woefully behind here in the United States. And so that's part of my drive, is just like getting more exposed.
Sure. Now, what is Shockwave? How does it work mechanistically? What is it that we're actually doing?
Yeah. So there's multiple types that are out there. I just brought up radial pressure wave. When you look at a radial pressure wave machine like this, it's essentially a small bullet going back and forth through this tube, and it's air pressure. So that's why the energy on here is based on bars. So if you're a cyclist, the tube in your bike is based on bars. So it's air pressure. It sounds like this when you hit it, right? So that's the bullet going back and forth a bunch of times. And you can see we have multiple tips here. So depending on the tip you have and what that substance is that bullet's hitting determines kind of how deep and how wide the wave goes. When I do talk about the difference between this and then this machine, which is utilizing electromagnetic forces to be able to provide a wave coming out of the tip and end of that, this is like dropping a pebble in water. And so you hit that water surface, the highest amount of energy and the tightest amount of concentric circles at the skin level, and then it dissipates down through the tissue. This is more like an hourglass.
And this is the focus.
This is the focused device. So focused shockwave, right? And essentially it's not as much energy at the bell, and then it travels deep into the tissue, and it kind of makes that hourglass shape, really intense energy at that specific spot, and then it dissipates from there. So knowing your equipment like this, and knowing what's your difference going to be between using a ceramic tip that's this small and how focused and how deep that is versus something larger that might be like nickel, gives you an idea of what type of tissue and space that you want to treat, and then knowing kind of how deep everything goes, where if you have a step off for this, it brings the energy closer to the surface. If I take this off, it allows it to go deeper into the body.
Got it.
Right.
So you started with Radial. What pathologies were you treating with Radial, and what made you go to Focus? And then second to that, what pathologies are you treating with Focus?
Yeah, good question. So as I stated, I was working with my father at the time, and after having used the Radial on myself, I said, wow, there's probably some rehabilitation potential from this, where in particular, like my dad's specialty were knees and shoulders. So he'd do a ton of rotator cuff surgeries, and these patients would often come back, and I'm sure you've seen them before. They come back post-surgically. Like, oh my God, it's
Big
their
time.
shoulders in their ear.
Yeah.
That's where most of that pain and dysfunction comes from, is just all those tight muscles. I just literally post-surgically started using Radial on these people. Just say, hey, how are you feeling? I maybe started with 3 sessions, and they would come back every week and be like, God, it's getting better and better. And then I started having physical therapists call me and be like, what are you doing? Something's changed.
What's changed?
What is changing?
Yeah.
So from there, I started, delving more and more in the research, recognizing that there's really good research behind plantar fascia, Achilles, calcific tendonitis for shoulders, right? And so I was staying within those parameters for a while, but then that's when the data started coming out with a lot of myofascial syndrome and how this can be helpful for that. Once I finished up my practice with my father and I moved to Oregon, I was in a practice that was doing more spine and more biologics for that. And that's when I expanded to utilizing both of these together and then utilizing the focused more for even spine conditions.
Yeah.
So,
And that's mainly a penetration issue, right? Where the Radial just can't get to maybe the facet joints or what you're trying to hit. That's where you need the focused.
correct. And then in addition to that, Focused has some special qualities to it, in that the ability to fix stress fractures, non-union fractures, bone marrow edema, right? So when you're talking about some of those bony conditions, Radial's not quite your go-to for that, but the Focus can be dramatic in terms of that improvement.
And you mentioned the post-surgical. I think there was a paper on post-Achilles surgery using, I believe, Focused that showed improved healing. Why aren't more people using these for, because, I typically will see folks trying to avoid surgery, get Shockwave. But there seems to be probably a good subset of patients that could benefit post-surgery. Would you agree?
Absolutely. And I, when I talk to somebody about them having a tendon issue, right? I usually let them know, typically the tendon is a victim of the overall myofascial chain that's abnormal, right? In particular, the muscles. So, unless you have really bad trigger points, right? Frequently, the muscles aren't the first thing that people recognize as being the painful source. They say, oh, my elbow right here, and you go, oh, you have tennis elbow. And for years, like you and I have done, oh, we'll approach where you're painful. But you have that subset of patients that don't get better. And I think we long ignored the whole chain that's related to that. This where Shockwave comes in for me. So it's like, if you're getting that 80th percentile, success rate for something, and you just can't break through for a subset of patients, adding this in the entire chain, and then stimulating like what you're doing from a synergistic approach of your biologics, can maybe make all the difference for somebody.
Got it. Now, so take us through a potential algorithm. So tennis elbow, they're also getting referred pain into the forearm. How are you going to look at that, combination-wise, doing Radial and Focus?
Yeah. So there's no set, protocol to follow in terms of like when to do the biologics, when to do the Shockwave. That's sort of up in the air right now. The way I do it is honestly patient comfort-wise and logistically. The way I think about it is, if I've talked to somebody about doing, a PRP injection or MFAT injection for their tendon, they're already kind of nervous about that. And then I bring up, hey, I'm going to use electromagnetic and radial pressure wave to shoot into your body. They're like, whoa, I'm totally freaked out. So I usually tell them, let's have you come in, do your full session of Shockwave, get used to it and get a feeling for it. On top of that, I know that there are going to be some synergistic benefits from them doing it before then anyway.
Yeah.
But then them getting used to what that's going to be before I bombard them with all the biologic stuff, I find helpful. So my protocol, my typical protocol for a tendon problem with trigger points, myofascial problems, would be first week they get their full Shockwave session. Second week, they come back for their biologics and get their second Shockwave session. And then they typically get 4 more sessions each subsequent week with both machines. And then I'm pretty aggressive about getting people into rehab and PT. So this is a terrific way to bridge that, of calming some of that initial inflammation down and then bridging them into their physical therapy program.
So you almost use this as a primer the first 2 weeks.
Yes.
And then do you do the injection the same day as the second, or you bring them back?
Again, that's where logistics comes in.
Got it. Sure.
Yeah.
Sure.
So, the data's not there yet in terms of you should do Shockwave first and then the PRP injection, or you should do it after.
Yeah.
The closest we've kind of have a direction on that is that there was a study that was done that utilized focused Shockwave that activated PRP. And again, this is bench research, but they activated PRP that then was put into a petri dish for growing osteoblasts, right? And having that activated, and it actually activated that better than the control group. So I extrapolate a little bit of that to say, like, if you're doing an IO injection with PRP into a bone marrow lesion, probably makes sense from that study to do the focused Shockwave afterwards.
Yeah. I've had a philosophical difference. Some folks have been big time proponents of just doing it all before because they're like, well, once I do the PRP injection, I don't want to mess up the response. Yeah. And I guess my response to that is, well, you can't have it both ways, right? If Shockwave is stimulating and it, brings blood flow, it enhances, tendon healing, you can't tell me that it's going to do the opposite just because you added PRP, right?
Exactly.
But I agree the data is not there, right?
The data is not there.
I like kind of your best of both worlds approach where you get a couple before, kind of get it moving, and then do the back, for afterwards. I think that's probably a good idea. We've probably been doing PRP and kind of waiting a little bit longer, like maybe 4 to 6 weeks, see how they respond. And then if they're not doing as well as we had hoped, maybe we start to add the Shockwave. But there's also patients who have asked me, well, can I just do the Shockwave? And I think the answer is yes. I personally don't think it's going to hurt, right?
Absolutely.
It's kind of like a combination therapy, if you will.
But to that point, just like your biologics, you have to know where you're putting it in the body and what your potential success could be with that. To know, do I think that will be an effective thing to utilize it for or not, right? I mean, I wouldn't turn anybody away if, they were like, hey, I want to just try the Shockwave. Okay, that's fine. But knowing that there's going to be a big difference in terms of potential for it if you're looking at tennis elbow versus the Achilles, right? Just like it is with our biologics, right? So, I think it's important for a biologic doc to know what is about the success rate that we'd be looking at a high quality PRP for a tennis elbow versus an Achilles. The same thing works for this, right?
Got it.
So letting them know that and understanding those protocols.
And, I won't make you quote specific percentages, but in general, what are your top 3 home runs with Shockwave and what are some that maybe don't do as well?
Yeah. It's actually interesting because I use Shockwave on so many people.
And then you get surprised that one that you didn't think was going to work actually works, right?
Yes. So in terms of like success in the literature, right? It's very well established for, like I said, plantar fascia, Achilles, calcific tendinosis of the shoulder. So those are very well established ones. In addition to non-union fractures, have very good data behind them. However, that's not always coming through our door. And a lot of the things, and I would say the vast majority of what I see and I try to apply this to, are some of those more stubborn things that seem to like cover a bigger area. Where I would say that this would be huge for somebody's practice if they don't have it, you deal in a lot of shoulder problems that also like connect to the cervical neck, Shockwave's great. You have a lot of lateral hip, right? connecting to the glute problems, SI joints, right? Low back, doing the facet, arthropathy can be very beneficial for this. So like those are the types of things that you can really make a huge difference for patients that just have not been able to find relief for anything else.
For stress fractures, you brought up a good point. I know there was a study by Belling which showed 98% to running after acute stress fracture, I think in approximately 12 weeks. How soon, do you give the stress fracture its natural course, like the 4 to 6 weeks before you start getting to Shockwave, or you're like, hey, you have a stress fracture, you're probably going to heal faster if we do Shockwave? Where do you stand on that?
Yeah, I mean, again, to me, it's like kind of all about the diagnosis there of like a stress reaction versus a stress fracture. I see those recovering in different ways. So I think you've probably seen before those really chronic stress fractures that somebody's just miserable with.
Sure.
That might take 6 months or more, even if we do really high quality focused Shockwave.
Yeah.
But I've seen people with lower grades of that or stress reactions, maybe like from an MTSS, of utilizing focused Shockwave and then making sure the myofascial chain's freed up, that they do get better in 4 to 6 weeks and they feel very comfortable from that. Right.
Okay.
And then it also depends, like if you're applying that to say something like a PARS injury, right? There's pretty moderate to good data about utilizing Shockwave and promoting healing in that, right? But that's probably going to take you longer, like it does for most.
Sure.
And so it's like, where do our studies come down where you take the traditional path, right, as a control group of just kind of a wait and see for somebody that has a PARS? Can we reduce that by 3 weeks, 4 weeks, 6 weeks? I mean, like that's where I think we need to start thinking about this. And it kind of goes to a brand new study that came out of utilizing focused Shockwave post ACL, which was a very well done study. And they found just utilizing a focused Shockwave like this unit in 3 different areas directed into the surgical knee got those players back in half the time than the control group.
Wow.
So we're talking like 25 weeks to 42 weeks type of range.
Significant
difference, right?
Yeah. Now, with bone, do you even bother with radial for stress fractures, or do you go straight to focused only?
Straight to focused.
Okay. And, with PRP, kind of a big topic is platelet dose, right?
Yes.
Do we have the dose yet for focused shockwaves for stress fracture, or do we know yet?
Yeah, so I would encourage everybody to look at the ASMST website. That's the International Society for Medical Shockwave Treatment. They very much have kind of laid the groundwork for guidelines, particularly the ones that have been around a long time, like for stress fractures and things of that nature. They also give good guidelines in terms of contraindications for these things. But with that said, I think you have to know your machine, and you have to know the tolerance of what people are going to have. In general, when you're talking about focused shockwave specifically for bony conditions, it has to be on that high energy level. And so for those of you who have not felt it, getting to a high energy level like a 0.3, 0.35, 0.4 millijoule per millimeter squared, that is a lot of energy. When they already have a very tender bone, they might not be able to tolerate that. So what I have seen though is, the larger bones, you probably do need closer to that energy level. But some of the data shows that, say you've got a base of the 5th metatarsal non-union, the lower energy ranges can be effective for that because it's so close to the surface, so you probably get enough energy through that space. Yeah,
it's crazy. When you get to 0.3, 0.4, they actually feel it like to the other side.
Totally.
Right? It's like it's intense.
I've
actually felt it myself.
You felt it yourself. I had one the other day. I was using this exact thing like this, and I was doing an Achilles tendon, and I had it going, and we're probably at 0.15 or so, and I was pushing on her tendon to make sure that I was tracking it. And I'm like, something hurts. And I felt it literally transmitting through my finger into my hand.
How crazy is that? All right, so what about for tendinopathy? We talked about bone dose. Is there a different dose for tendinopathy in soft tissue, or kind of similar as much as they can tolerate?
So for everybody, if you want to look a lot of these things up, Dr. Karsten Knobloch out of Germany is a terrific source for this. And when he gives lectures, he gives a very good kind of span of energy levels to give you sort of an understanding of the range of what you're looking for. We've already talked that higher range level is pretty much 0.25 and above for bone. The next section down would really be for that muscle tendon range. So you're looking at like 0.25 down to probably about 0.10. And by the way, these numbers are in millijoules per millimeter squared, specific to focus shockwave, but you can have like a correlation to the bars, right?
Okay.
You can look that up. And then below kind of that 0.10 and down, you're looking at more sensitive tissues and in particular nerve. So it's something that Dr. Knobloch refers to as nano energy. It's going to be sort of that 0.07 to 0.01 range. Got
it. And what about treatment frequency and how many treatments totals do you do?
Yeah. A lot of the literature you'll find, particularly like pre-2005, I would say, standard was 3 sessions.
Okay.
And who knows what that, like how arbitrary that was. I think it's a lot like our early data for PRP that was combined with or compared to HA, where everybody did 3 of HA, so we'll just do 3 of PRP, right? You know, I think it's probably similar to that. But we had a experts consensus that got together of a lot of the American docs that do this, and then some of the international docs. And our consensus came that 6 was the typical kind of average range around there. And from a physiological standpoint, you find that substance P actually drops dramatically after that 5th session.
Okay.
So that 5th to 6th session is really where they're like, ooh, I've
really
turned a corner.
Got it.
And then they get that 6th one and you're like, okay, let's give this its time, right? And then we'll see where you're at in about 3 months.
Okay, so that's a good point right there. So you've finished the 6 weeks. How long does it take to take effect?
Yeah. So I will see people at about the 6-week mark after the last session. Okay. And the way I discuss with them is I don't expect you to be completely great right now, even though sometimes people are. I want to see where they are because I would expect progression at least above 50% from where they were from baseline. And then they should be working their way into like a physical therapy program or a training program, or they're getting back into the gym. And I want to lay them a good foundation, letting them know, listen to your body.
Yep.
But I would expect us to continue to improve to about that 3-month mark. Now, there's a surgeon in Germany that does mainly just focus shockwave. He says, I will not see anybody until the 3-month mark.
3 months.
I will not see anybody. And he says, you just physiologically does not make sense to like change anything before that time at all. And so I kind of stick with that. And so it's rare for me to make any sort of intervention, including an extra shockwave, before that 3-month mark.
Got it. So yeah, I typically see folks at 6 weeks, see how they're doing. And then, I expect them to be at least trending in the right direction. Yeah. But 3 months is kind of like, all right, this is, I think, a good dose.
Yeah.
Now, how do you pick, obviously with focused, the heads just change based on kind of the depth that you want to range.
Correct.
What about for radial? I think that's a little different. How do you pick which head you want to use?
Yeah, it's a little bit harder. So, we talked a little bit about it before. We have that one, which is a wide one, and this is gonna have a large concentric circle, and it goes pretty deep. This can get pretty heavy in terms of like the energy level. Yeah. And I certainly wouldn't be doing this like around an ankle, hand, wrist, or anything like that.
Like a hamstring?
A hamstring is probably a good spot. Yeah. Hamstring, quad. I'll sometimes get into the bigger shoulder muscle girdle is okay. This, as I pointed out before, is more of a ceramic tip. This is going to be softer. Yeah. It doesn't have as much energy depth to it here. And then this is, I believe, nickel or something like that, but this is going to be much more intense, right? Okay. And that's going to be more of a focused wave, but much deeper.
Yeah. Okay. And let's say you are using radial, you're trying to cover a larger surface, or even when you're doing focus and tendinopathy, do you just treat one spot? Do you move around? Yeah. And then do you range the joint or the muscle as you're, almost like some myofascial work while you're doing the shockwave?
Yeah. So I'll start with kind of the area that you treat. When we had that expert consensus together, we decided to make it as simple as possible. If you have radial and you're treating an area, let's say like we're doing tricep, it's the area of a dollar bill. Okay? When you're utilizing your focused, an area of a quarter.
Okay. So you really want to stick to
really stick to it. But if I'm showing you and it's a quarter, it's not like I'm just like, ugh. I'm trying to find the hottest spot that they have, but I'm doing kind of little emotions from it, right?
Okay.
And it's slow, but intentional. And so if you're utilizing something like this and I'm doing the dollar bill, it's really kind of slow, and you want to have some indentation of that tissue as you're going through.
Okay.
Don't paint as you're not doing anything. Provide enough pressure to it too. If you're too light, it's not doing it either.
Okay.
Right?
Got it. So there has to be some feedback there where you're feeling like you're pushing down.
Yes.
Is this meant to be, for PRP, for instance, when someone comes in with relatively advanced OA, I tell them, look, this is not a cure. This is a 1-year deal, hopefully.
Yeah.
You're likely going to need to repeat it. With Shockwave, what are your comments? Is this meant to be permanent, or when is it just a pain reliever and they're going to need to come back?
Yeah, I very similar to you in terms of the biologics. I would say my conversation's similar when it comes to Shockwave also, in that anybody that comes into my office and they got these chronic degenerative conditions, I try to lay the groundwork from the start for anything that I do that it's probably going to be maintenance.
Yeah.
I'm not fixing anything. I'm not curing anything. In some cases we might.
Yeah, especially soft tissue.
Especially soft tissue. But
or bone, sorry, that would be the
or bone, right? I mean, they're like conditions such as that of like a non-union stress fracture. Maybe you can use that language.
Sure.
But for most of the stuff that we deal with, right, it's going to be a maintenance of some kind. But what I tell them is, you have pain and dysfunction right now. If I can get you to a state where you're like, most of the time during the week, I don't think about this body part anymore, and I'm functioning pretty well, and it doesn't register for me, I see that as success. Yeah. And if we have to utilize this again because Shockwave did great for you, and we do 3 sessions here and 3 sessions there, and that kind of keeps you maintained and hones that area that was a problem, that's success to me.
Is there a way to modulate the amount of energy you deliver to create more of just an analgesic effect? So I did hear of some professional athletes getting Shockwave at halftime instead of getting lidocaine injections, to try to just provide an kind of almost an anesthetic effect so they could play the second half. How do you feel about that? And is there a certain range, like the I guess anesthetic effect of Shockwave?
It's actually interesting at our ASMST meeting that we had in March last year. I forget who it was. I think it might have been Luger Gertesmeyer, one of the Germans. But he brought up, is there going to be a point in time where the WHO actually outlaws Shockwave? And it can be that profound. Sure. There can be such a reduction in terms of the nerve projection that you feel into that space that they literally do not feel it anymore. Now, that can be dangerous because they might go out just like you would if you threw some lidocaine in there and you still have an injured site and you don't feel it as much. But I would still argue, as opposed to putting chemicals into a site to knock that out, it's at least healthier. But I don't like to typically do this for patients if they come to me, they go, hey, I got a marathon tomorrow, I got to run it. I just want this 1 session of Shockwave. Do that for me so I can go run it. That's not what the intention of this is for.
Sure,
right?
Understood. It's almost like you understand what pathology they have. More than likely, if they can't feel it, they're not going to do themselves more harm.
Yes.
You wouldn't do it on a stress fracture, so they can't feel it the next day at the marathon.
Exactly right. That's exactly right.
Perfect.
And so, one of the lines that they talk about at Curomedics is, this is the only non-invasive, evidence-based treatment that not only treats the symptoms, but can help with the underlying problem. And the reason I bring that up after your question is, yes, it can treat that symptom of pain, but our eventual goal is to actually change the issue that is happening in that area.
One of the big benefits I see to Shockwave, when I talk to my patients about, okay, do we do a biologic, do we do Shockwave? I also ask them, well, how functional are you right now? Are you having any trips? Is this your tennis season, right? And you can still play, it hurts, but you're fine. Then we should go Shockwave, because if we're going to do biologic, we're probably going to shut you down. Are you okay with people continuing to be active? How soon after a Shockwave treatment, or even they're like, well, I have PT later today. Can I still go, or should they turn it down?
Yeah. Very complex conversation.
Sure.
Yeah,
I mean, we just said we're doing it at halftime.
Yeah,
right?
yeah, exactly. I just said, like, I'm not going to do it right before you do, a marathon. But
I guess it depends.
It's a very much it depends. Now, I love utilizing it for in-season athletes. But one of the major studies that they did of evaluating how athletes recover from something like this is they did a study of, I think it was the Bundesliga for soccer in Germany. They evaluated a cohort that both groups did Shockwave, but one group came back to a lesser percentage of their training schedule during and 6 weeks after the Shockwave sessions, and then one group went right back to their full training during the 6 weeks of the sessions and then the 6 weeks after. The ones that went back to full training did not do as well as the ones that cut back to a certain extent. Now, that's very hard to quantify for most people, right? Sure. So it's why I always have that conversation and I quote that data just so they have an understanding that they can't just go out and, play 5 sets of tennis and they're going to be all right. Right. There's still going to be an impact of that tissue that's dysfunctional to some extent, right? Okay. So you have to regulate that in some manner. However, I'd much rather a player come do Shockwave with us through their season and like instill some sort of change into that tissue than doing nothing at all.
Doing nothing at all. Perfect. Now, for someone who wants to bring Shockwave to their practice, what's kind of the advice to bring it in? They're like, well, is it going to cannibalize my orthobiologics, or is it, how do I incorporate it into my treatment algorithm?
Yeah, it's a good question. So when I first brought this on board back in San Jose when I was working with my dad, I kind of had a menu of items. And I would say, we could do Shockwave, it's non-invasive. We could do PRP, we could do MFAT, BMAC, or you could talk to my dad about surgery, right? And it was just sort of like this laundry list. Then looking through the data and then having the understanding of how that whole myofascial kinetic chain works, it's like, why are we not comboing this, doing this together? Sure. And so I started doing that years ago, and my thought process of it is, let's again take tennis elbow as an example. If you can get 80% success with a high quality PRP for tennis elbow, great. But that other 20%, can we start to inch up that percentage chance of that working by incorporating something like this? Because now we're hitting the chain, we're freeing that up, we're correcting the muscle dysfunction, we're releasing those trigger points, in addition to having something synergistic into where we did our injection. My answer would be yes. We're just trying to play a percentage game and improve that, right? And now the data is very new, but we're starting to see more and more data of evidence showing synergistic qualities between the biologics and the Shockwave. So my argument for somebody is, if you have a full-fledged orthobiologic practice, adding this just completely makes sense.
It's complementary.
It's so complementary to it. In addition to the fact that I truly believe in the future we'll see research that really shows a synergistic quality to this, that you're just going to have this if you're doing PRP.
Got it.
BMAC.
Now, when we talk about devices, before choosing the Curomedics, the Storz device, what were you looking for? What are the things you still look for in a good Shockwave device?
Yeah. When we're talking about like focused Shockwave per se, right? There's electromagnetic, there's electrohydraulic, and there's piezo wave, right?
Those are the big three.
Those are kind of the big three ways to create that wave that you're looking for. Right? And now there's multiple various companies that make all of these types of things. So what I would say is you want to apply it to yourself. See what it feels like. Right? Because then you have to kind of explain that to the patients, but then also having an understanding of depth of where you're penetrating with the energy. What's the range that you can accomplish with that energy? Talking to the companies about, do you have data on this or this, right? So really knowing your practice and what you're applying it for is going to be very useful, right? So if you have a bone heavy practice, you see a lot of stress fractures, you see a lot of athletes that have issues like that, you're probably going to need a focus device. If you are more of, very hands-on and you want to have an application of something that's, you really work on myofascial chain and kinetic chain type of issues, Radial might be better for you. there is data that shows that the combination of them are better than either one alone. So if you have that capacity and you want to bring that to your practice, you can elevate the game even more.
Even more.
Yeah.
Now, where do you see this going, right? What's the future of Shockwave look like? Is it just more adoption, better protocols? Do you see any big changes to some of the equipment? Where do you see it going?
Yeah. So a lot of the feedback I get, through the ASMST and when I was working with Curomedics and people trying to adopt this is, okay, I have this specific, CMC joint problem. You have to tell me the exact protocol I'm supposed to apply to my machines. And I'm always like, depends.
Yeah.
The answer is always it depends. There might be somebody that can tolerate 0.35 in here,
right,
and there's somebody that can only tolerate 0.01. Well, now you're way outside the protocol.
Yeah.
Right?
Yeah.
So we're trying to put together something where you can have parameters that cover the vast majority of the evidence out there, that you're working within the space, but it gives you leeway to be able to apply it to every patient that you see, to apply it in a good evidence-based way for whatever condition you're looking at, right? Now, some people are going to fall outside of that curve, but that's really the future that I'm looking at is, can we have a collective understanding of parameters for whatever device and energy levels that we're using to be able to hone in for the vast majority of patients to have success, right? Because right now, a lot of people are kind of out there doing their own thing, sort of like I was before I met, the Europeans. I want to hone that more for people here in the United States, and it's one of the reasons I, helped start the ASMST.
Can you tell us a little bit about the society?
Yeah.
Kind of give us, what are you guys working on?
Yeah.
How can we join?
Yeah,
Tell us a little about
yeah.
it.
So we started almost 2 years ago, and we have a strong connection with the ISMST that I mentioned earlier, so the International Society of Medical Shockwave Treatment. And we had our first summit in March in Boston last year. And we also had an ISMST certification program with that, in addition to a lot of the top docs that are doing research in Shockwave here in the United States. And so from there, we're trying to expand our board and then solidify like a membership so we can promote this even more and bring education out there. We're working on getting more sponsors and more manufacturers of different devices to come out so everybody can experience it. Because in my mind, the more that this can be exposed to everybody here in the United States, they're going to recognize, wow, there's a lot of benefit to utilizing this. So anybody that's interested in membership, it's asmst.org to become a member, and then see more information on our next summit that's coming up in March in Boston.
Great. Well, last question from a Shockwave perspective. I feel like Shockwave, as much as we try to standardize, is still somewhat of an art. And for instance, we have, one of my partners, one of our PAs was doing Shockwave, and even though we're treating the same body part in the same way, still using the same energy levels, the patient perceives a different treatment. And they're like, oh, well, when he did it, this and that, or like, doc, you're really getting in there today, right?
Yes.
How do you, and that's part of the art of it, right? Kind of like getting a deep tissue massage, depending on who is doing it for, is going to be different. But what are some tips or pearls, if the same patient is going to be going through different providers, that we can do to kind of make it a similar experience?
Yeah, and it again goes back to why I'm trying to kind of hone some sort of parameters to it. I don't want to call it protocols for the reason I said before. Because you could take this and you could say, oh, it's tennis elbow and it's 2.5 bar for 2,000 shocks. But then they take that same thing and they're doing this. That patient's not going to do well. It's just not applied correctly. So there is an art to this, right? And so there does have to be parameters that you kind of stay in to have the most success. Now, you can still be in those parameters. You and I can do the same energy level. It could feel entirely different for that patient, right? And I've trained a lot of people, including 3 other techs that have worked in my offices before. They are all different. And I make sure that they work on me so I understand those differences. And I very much have patients that get multiple of those people and they say, ooh, I don't like that person, but I like this person better. Very similar to what you say about a deep tissue massage. You're gonna have a masseuse that's different than the other person, right? And so that's why I say you gotta know your equipment, you got to know the patients that you see, you have to know your population, and you have to know the applications of what you're using it for. Because then you can start to hone and really achieve that art type of level, knowing that you're like, okay, I know this type of patient, and I think they're going to do really well because I've seen so many of them before and I know how to apply it.
Gotcha. So we'll do a rapid fire to close.
Okay.
This is going to be quick.
Yes.
So I'm going to push you to the limit here.
Yes.
All right. One word answer.
Yes.
Radial or focused?
Focused.
Best indication to treat?
Oh, non-union fracture.
4 or 6 sessions?
6.
All right. That does it, man.
Love it.
Hey, thank you so much. This
Thanks,
was
man.
awesome.
I appreciate it.
I hope you guys learned as much as I did. Please don't forget to like and subscribe to our channel if you like all our content. Thank you again to Dr. Brice Blatz. He's the man with Shockwave. Please feel free to reach out with him if you need more treatments as well as us. Have a good one.
Bye, guys.